Imagine this. You've just come back from an amazing trip, maybe Southeast Asia, maybe the Caribbean. Beautiful places.
Yeah.
You've got great memories, but then slowly things start to feel
hmm
off. Stomach problems that just won't quit. You're tired all the time, losing weight for no reason.
hmm
You see doctors, but they're stumped. It's not just a simple stomach bug. It's like this medical mystery you brought back in your suitcase.
It's a scenario that unfortunately does happen, a kind of unwelcome souvenir.
Exactly. Welcome to the deep dive. Today, we're tackling exactly this kind of puzzling situation. Tropical sprue. It's a condition that really shows how interconnected our environment and our internal health are.
Often in ways we don't expect. Right. We've gathered, a pretty comprehensive stack of research, metalworkers, all about tropical sprue.
And our mission today
Is really to sift through all that, pull out the crucial bits. We want to give you a clear picture, a concise understanding of what tropical sprue actually is, and maybe provide a few of those aha moments about the gut and the environment.
Okay, let's start with the basics then. What is tropical sprue, fundamentally?
Right. So, simply put, it's what we call an acquired malabsorption syndrome. Acquired, meaning you're not born with it, you pick it up.
Okay.
And malabsorption means your body suddenly has trouble absorbing nutrients. It mainly affects people in or traveling through specific tropical and subtropical areas.
And what's happening inside the body?
The core issue is chronic inflammation and damage, specifically to the lining of the small intestine, mostly in a part called the jejunum, which does a lot of the heavy lifting for nutrient absorption.
Ah, okay. So the gut lining itself is the problem.
Precisely. And
Right.
that leads to a really key point about diagnosing it. It's a diagnosis of exclusion,
Meaning?
meaning doctors have to be detectives, basically. They have to rule out everything else first, celiac disease, parasites, you name it, before they land on tropical sprue.
Not because it's super rare, but because it looks like so many other things.
Exactly. The symptoms are broad. It's a real mimic.
That does sound like a challenge. All right, so given that, where does this thing actually, hang out? What's its global footprint? The geography sounds pretty interesting.
Oh, it's fascinating. It has this very specific geographical fingerprint. It's endemic, meaning it's just consistently present in places like the Indian subcontinent, a lot of Southeast Asia,
Like Philippines, Vietnam.
Philippines, Vietnam, Malaysia, yeah. Parts of the Caribbean too, Puerto Rico, Cuba, Haiti, and bits of Northern South America. These are the hotspots.
But the really weird part is where it isn't, right?
That's the peculiarity.
Hmm.
It's notably rare in places like Africa or Jamaica or Saudi Arabia, even though the climates might seem similar.
So it's not just about heat or general tropicalness.
No, definitely not. It suggests something much more specific is going on. Maybe specific microbes or environmental factors, maybe even subtle genetic predispositions in those populations. We haven't quite figured that part out.
Hmm. So who's most at risk in these endemic areas?
Well, obviously, long-term residents can get it, but it also affects visitors and expats who spend, months or even years there. That's often called traveler sprue.
And it doesn't discriminate much otherwise.
No, it hits all ages, though it's less common in kids, all races, both sexes. And it can pop up either in epidemics, affecting a group, or just sporadically as single cases.
It really makes you think about travel health differently, doesn't it? Beyond just packing meds for travelers' diarrhea.
Absolutely. It's a reminder that some place-specific health issues have a much longer, sneakier timeline, that invisible souvenir.
Definitely don't want that one. Okay, so this brings us to the big question. What actually causes tropical sprue? You said the origin is unknown, which is kind of the core of the mystery.
That's right. The exact trigger is still elusive. But the leading idea, the main hypothesis, is that it starts with some kind of infection, maybe bacterial, maybe viral, in someone who's susceptible.
And the infection just sticks around
Right, yeah.
or leaves lasting damage.
Yeah, it seems like the initial infection doesn't fully resolve. It kicks off this persistent chronic injury to the gut lining. It really highlights how an initial hit to our gut environment can spiral into a long-term issue.
Okay, let's dig into those theories. One big one is bacterial overgrowth, right? What does that involve?
The idea there is that certain types of bacteria, specifically toxigenic coliform bacteria, think Klebsiella, some E. coli strains, and Enterobacter, start growing excessively in the small intestine.
Where they shouldn't be in large numbers.
Exactly. They're in the wrong place. Or there are just too many of them. And crucially, they produce toxins, enterotoxins, that directly damage that delicate gut lining. It's the toxins do the harm.
Right, bad bugs making poison in the wrong spot. Makes sense. What about viruses? Any theories there?
Yes. Another angle is a persistent viral infection. Maybe someone gets a bad case of viral gastroenteritis, like from rotavirus or maybe even a coronavirus, and instead of clearing up completely.
It just lingers somehow.
Or it triggers a chronic inflammatory response that just keeps going, keeps damaging the gut lining long after the initial virus should be gone. A sort of viral hit and run that leaves chronic damage.
Interesting. But it's not just infections coming in, right? You mentioned nutrition plays a role too.
It does, sort of in perpetuating the problem. Chronic nutritional deficiencies themselves can make things worse. Take folate, for example.
Okay.
If you're chronically low on folate, your gut lining can't regenerate properly. It's constantly renewing itself, normally, but without enough folate, it can't repair the damage effectively. So the injury sticks around, maybe gets worse, it fuels the fire.
A vicious cycle. And what about our own immune system in all this?
Well, the fact that there's so much inflammation points to the immune system being involved. It's possible the body's reacting abnormally, maybe overreacting to the bacteria or their toxins, or maybe to the lingering effects of that initial infection.
So the immune response itself could be contributing to the damage.
Yeah, instead of fixing the problem, it becomes part of the problem, causing ongoing mucosal injury. It's a complex mix. Microbes, maybe diet, and definitely the immune response.
Okay, let's trace that damage. What actually happens inside the gut once tropical sprue gets going? You described it as a vicious cycle, a domino effect.
That's a good way to put it. It starts with step one, mucosal injury. That initial trigger, whatever it is, causes inflammation and this key feature blunting of the villi.
The villi, those are the little finger-like things.
Exactly. Tiny projections lining the small intestine, especially the jejunum. They massively increase the surface area for absorbing nutrients. Think of them like the fibers on a fluffy towel.
So when they get blunted,
That leads straight to step two, reduced surface area. Your fluffy towel becomes a flat, worn-out sponge. It just can't soak up nutrient efficiently anymore. The absorption area shrinks dramatically.
makes sense. Less surface, less absorption. What's next?
Step three is enzyme deficiency. Because the surface is damaged, you lose some of the crucial brush border enzymes located there. Lactase is a big one.
Ah, the enzyme for milk sugar.
Right, so you often get secondary lactose intolerance. People suddenly can't handle dairy well. That's a common early sign.
And all this leads to the main event.
Step four, malabsorption. The damaged lining just can't do its job. Fats, carbs, proteins, crucial vitamins like B12 and folate, minerals, they just pass right through instead of being absorbed.
Wow. Okay. Is that the end of the chain reaction?
Not quite. There's step five, bile acid malabsorption. Bile acids, which help digest fat, are normally reabsorbed further down in the ileum. If that part's also affected, they spill into the colon.
Causing more problems.
Yes, causing a specific type of diarrhea called secretory diarrhea. More water loss, more distress.
And finally,
Step six kind of loops back. Because everything's slowed down and damaged, we call that stasis, it creates a great environment for even more bacterial colonization.
so the bacterial overgrowth gets worse.
It can, yeah, which then causes more inflammation, more damage, more malabsorption. It really becomes a self-perpetuating destructive cycle.
What a cascade. Okay, so that's the internal picture. How does this manifest on the outside? What symptoms should someone be aware of? You mentioned it starts slowly, insidiously.
Exactly. It creeps up on you over weeks or months, which makes it so tricky. It's not like food poisoning where you're sick suddenly.
But there's a classic triad of symptoms doctors look for.
Yes, a typical pattern often emerges. The first part of that triad is chronic diarrhea.
What kind of diarrhea are we talking about?
Classically, it's described as pale, bulky, greasy, and foul-smelling. That's called steatorrhea, basically, fatty stool, because you're not absorbing fat. Yeah. But importantly, it can start out just being watery diarrhea, so it doesn't always look like that classic fatty stool initially.
Okay. What's the second part of the triad?
That would be weight loss and malnutrition.
Yeah.
Because you can't absorb calories, protein, anything really. People lose significant weight progressively. They can be eating, but they're essentially starving internally.
Chronic diarrhea, weight loss, and the third. This is where it gets systemic, right?
Right. The third is nutritional deficiency syndromes. This is where the gut problem really ripples outwards and affects the whole body because you're missing key building blocks.
What are the big ones?
Folate and B12 deficiency are huge. They cause a whole constellation of issues. You might get glossitis, a sore, red, smooth tongue, debilitating fatigue. and a specific type of anemia called macrocytic anemia.
Macro, meaning
Wow.
large cells.
Yes, the red blood cells become abnormally large and don't function well because they can't mature properly without folate or B12.
Mm.
And B12 deficiency specifically can also cause neurological problems.
Like nerve damage.
Exactly. Peripheral neuropathy, tingling, numbness, sometimes weakness, often in the hands and feet.
Wow, what other deficiencies pop up?
You can see vitamin A deficiency leading to night blindness or dry skin, vitamin D and calcium deficiency causing osteomalacia, soft bones, bone pain, even muscle spasms or tetany, and protein deficiency leading to muscle wasting and edema, which is swelling usually in the legs due to low protein levels in the blood,
Yeah.
plus just general weakness and lethargy.
So a sore tongue, anemia, nerve damage, weak bones, swelling. It's incredible how a problem starting in the gut can cause such widespread chaos.
It really is. It drives home how dependent the entire body is on proper nutrient absorption. A localized gut issue becomes a full-body crisis.
Given all that complexity and the overlap with other conditions, diagnosing this must feel like, well, like real detective work.
It absolutely is. And that starting principle is key. It's a diagnosis of exclusion. You have to rule other likely culprits out first.
So where does the investigation begin?
It always starts with the patient history. That is absolutely critical. Has the person lived in or traveled extensively to an endemic region? That's the first most important clue. Without that geographical link, tropical sprue is way down the list of
That
possibilities.
makes sense. Okay, after the history. Labs, I assume.
Yes. Laboratory findings are next. Blood tests are crucial. They'll look for that macrocytic anemia we talked about, low hemoglobin but high MCV, meaning large red cells.
Confirming the folate and B12 issue?
Exactly. They'll measure serum folate and B12 levels, which will typically be low. They'll also check albumin levels. Low albumin points to protein malabsorption. You might also see low calcium, low vitamin D, maybe problems with blood clotting time due to vitamin K issues.
Any specific tests for the malabsorption itself?
Yes, a really important one is the D-xylose absorption test. D-xylose is a sugar the upper small bowel should absorb easily. You drink it, and doctors measure how much comes out in your urine over a few hours. If not much comes out, it means the upper bowel isn't absorbing it properly.
A functional test of the gut lining.
Precisely. And to specifically confirm fat malabsorption, the gold standard, though cumbersome, is a 72-hour fecal fat collection. If you're excreting more than about 7 grams of fat per day, that's abnormal.
Okay, so labs point towards it. What's the definitive diagnostic step to actually see the damage?
That requires looking directly at the tissue. An EGD esophagogastroduodenoscopy with small bowel biopsies is the key.
So an endoscopy where they take little tissue samples.
Exactly. They take biopsies from the duodenum and, importantly, the jejunum. Then the pathologist looks at them under the microscope for the characteristic histological findings, partial to potentially total villus atrophy, those flattened villi. Crypt hyperplasia, the little glands between the villi get longer, trying to compensate, and increased inflammatory cells, lymphocytes, plasma cells packed into the tissue layer beneath the surface, the lamina propria. It shows the ongoing inflammation.
But you mentioned a catch earlier. These changes look like something else, too.
Yes, and this is absolutely crucial. These histological changes are not specific to tropical sprue. They look very similar, almost identical sometimes, to celiac disease.
So how do you tell them apart?
This is where everything else comes together. The travel history is essential, and you need negative celiac serology. Blood tests for celiac antibodies like TTG-IgA must be negative. If those are positive, it's celiac. If negative and the travel history fits, then you strongly consider tropical sprue.
So ruling out celiac is paramount. What else needs to be excluded?
Oh, definitely. You need stool studies for common parasites like Giardia, Cryptosporidium, strongyloids, maybe a hydrogen breath test to check for SIBO, small intestinal bacterial overgrowth, or lactose intolerance, though SIBO can actually coexist with sprue sometimes.
Right.
And depending on the location and patient, you might need to rule out things like HIV-related gut problems, Crohn's disease, even intestinal lymphoma, or issues with the pancreas. It's a thorough process.
It really highlights how meticulous doctors need to be. That diagnostic journey sounds intense.
It requires careful consideration of all the pieces of the puzzle.
Okay, so after all that detective work, a diagnosis is finally made. Tropical sprue sounds daunting, but what about treatment? Is recovery possible?
Thankfully, yes. Despite the mystery surrounding its exact cause, the treatment for tropical sprue is surprisingly effective. It's a two-pronged approach: nutritional support and antibiotics.
Let's break that down. What's the first priority?
Nutritional supplementation is absolutely job number one. And the star player here is folic acid.
Really? Just folate.
High-dose oral folate, usually 5 milligrams a day, is considered the cornerstone. It often produces a really dramatic improvement, sometimes within days. People feel better, the anemia starts correcting.
Wow.
And what's fascinating is that sometimes the folate alone can even start to improve the gut lining structure, the histology. It's quite
Nice.
remarkable.
That is amazing. What about the B12 deficiency?
That also needs aggressive correction. Usually with vitamin B12 injections like 1,000 micrograms weekly for a few weeks, then maybe monthly. Sometimes high-dose oral B12 can work later if absorption improves, but injections bypass the gut initially.
And other nutrients.
Yes, usually a good multivitamin, plus specific supplements for whatever else is low vitamin D, calcium, iron, vitamin A based on the lab results.
What about diet advice during this?
The goal is a nutritious, high-calorie, high-protein diet to help rebuild the body. And initially, because of that secondary lactase deficiency.
Dairy issue.
Right. A lactose-free diet is often recommended at the start to reduce symptoms like bloating and diarrhea while the gut heals.
Okay, so load up on nutrients, especially folate and B12. What's the other part of the treatment? Antibiotics.
Yes, antibiotic therapy is the second pillar. The traditional choice is tetracycline.
And that's for the bacterial overgrowth theory.
Exactly. It's aimed at knocking back that suspected bacterial overgrowth in the small intestine and breaking the cycle of inflammation. Usually it's given 4 times a day or maybe a higher dose twice a day.
For how long? A week or two?
Oh no, much longer. We're talking of significant duration, typically 3 to 6 months.
6 months. Wow.
Yes, it needs to be long enough to really clear things out and allow the gut environment to reset and heal. If someone can't take tetracycline, alternatives like doxycycline or cotrimoxazole Bactrim are used.
Any other support needed, maybe in severe cases?
In very severe cases with significant dehydration from diarrhea, fluid and electrolyte replacement intravenously might be necessary initially, just to stabilize things while the main treatments kick in.
So it's a serious commitment months of antibiotics, plus careful nutritional rebuilding. What's the overall prognosis? Do people fully recover?
The prognosis is generally excellent with treatment. Symptomatic improvement is often rapid diarrhea stops, appetite returns, energy levels increase, usually within days or weeks.
That's great news. What about the gut lining itself? Does it heal completely?
That takes longer. Full histological recovery, getting those villi back to normal, can take months, sometimes even years. And for some people, it might never be 100% perfect again, even if they feel fine.
And what happens if treatment stops earlier? Someone goes back to a place where Sprue is common.
Relapses are definitely a risk if the full antibiotic course isn't completed. And yes, unfortunately, going back to an endemic area can potentially trigger a recurrence.
And if left untreated.
The consequences can be very severe: debilitating malnutrition, profound weakness, and ultimately it can be fatal if not addressed.
It's really striking, isn't it? The cause is murky, maybe bacteria, maybe a virus, maybe immune reaction. But the treatment, especially that folate and the antibiotics, works really well.
It is. It's one of those cases where we have an effective how to treat it, even if the fundamental why it starts is still partly a mystery. The rapid response to folate is particularly fascinating.
So let's recap. Today we've journeyed into tropical sprue. It's this acquired malabsorption syndrome picked up in specific tropical spots.
Right. Its origins are a bit mysterious, likely an infection kicking off chronic damage to the small intestine lining, especially those villi.
Which leads to this cascade of problems: diarrhea, weight loss, and really widespread nutrient deficiencies affecting everything from your tongue to your bones to your nerves.
And diagnosing it takes real detective work, ruling out mimics like celiac disease, relying heavily on travel history and specific lab tests, and ultimately gut biopsies.
But the good news is the treatment hitting it with high-dose folate, B12, other nutrients, and importantly, a long course of antibiotics like tetracycline is generally very effective.
Bringing most people back to health, although full gut healing can take time. It really underscores that deep connection between where we are, what microbes we encounter, and how our body functions.
It definitely makes you appreciate how geography can shape health in unexpected ways. So we'll leave you with a final thought to chew on. Given that the exact cause of tropical sprue is still elusive and it has these strange geographic boundaries, what kind of research could help us move beyond just treating it towards actually preventing it? Could studying the specific gut microbiomes of people in those endemic areas, what bugs live there normally versus when sprue develops, hold the key?
That's a great question. Understanding those unique microbial signatures or maybe specific environmental triggers in those regions might offer clues for prevention. maybe through probiotics, prebiotics, or even targeted therapies someday,
Hmm.
moving from reaction to prevention.
Something to think about. That's all for this deep dive. We hope you found this exploration of tropical sprue insightful. Keep digging into the topics that capture your curiosity. Until next time.